Okay, good afternoon, everybody, and welcome to the webinar on Changing Language to Change Care, Stigma and Substance Use Disorders. My name is Mary McCarty-Arias, and I'll be your trainer for the next 2 hours. Anyway, welcome, and I'm really glad that people are here. Oh, we do have somebody, bienvenida. We do have somebody from Puerto Rico, as well as people from California, and my friends in New York and New Jersey. So this course was developed, it's probably developed about 2 years ago. And one of the reasons we wanted to talk about it was because when you look at stigma and stigma in our field, it's really important to kind of look at that. But when you look also at stigma, not just people who use substances are stigmatized, but also people with mental illness, people with HIV, LGBTQ people, people with disabilities. So this was a really, I think, good opportunity to look at language. And so we are, again, glad that you are here. Good. Hello from Buffalo. Prior to COVID, we used to travel up to Buffalo, Binghamton, variety of places in New Jersey. As of today, we're still all working from home. And when we find out otherwise, we'll let you know, but we will be doing webinars probably for the next few months, as far as I know. So let's go. So if you've been in our courses before, you know that we always have this disclaimer. And one of the reasons that we have the disclaimer is that the views, they really are representing us, the Northeastern Caribbean Addiction Technology and Transfer Center. They're not necessarily representing the official views of SAMHSA. SAMHSA is the Substance Abuse and Mental Health Services Administration. They're located in Washington or just outside of Washington, and they fund us, but this is our course. And if you see where it says PI M. Chappell, Mike Chappell is the director of the Northeast and Caribbean ATTC. We also put this in every course that we have, and I think it's particularly probably helpful for this course because we always talk about words having power, and this course will be dedicated to that. You know how we always talk about people first? So the person with the disability, the person with substance use, we'll be practicing that and looking at that for the next 2 hours. And that is a value that the ATTC network really promotes. So there's my picture again. And I know some of you personally. Now I have new friends from all over the country. I've been training for many years. I am a rehabilitation counselor by trade, and I started working in drug treatment and working with people with co-occurring disorders. And rehabilitation counseling is about getting people back to either their jobs, if they want to go back there, or for some people, finding jobs. In fact, I'm going to do a course probably in April on vocational rehabilitation. So that's something about why I also chose to do this course. My first job out of college, I was an English teacher, so I really love languages and how people use words. So again, next. So I will go over the housekeeping, by the way, and the guidelines, but I just want to tell you that this course was taken from a couple of sources, and here they are because they are public domain and you can have access to them, or Treat Chapel will be sending you copies of the slides tomorrow. And if you want to do trainings yourself, here's where you can go and get more information. So the AIDS Institute, we used to work before we moved to the New York State Psychiatric Institute. We were at NDRI, the National Development Research Institute, and we worked very closely with the AIDS Institute in New York. And so they came out with this course called From Stigma to Affirmation. You could probably take this course with them as well. In addition, there is something called the STR, the State Target Response. There's technical assistance, and that is a program that has been set up through actually the I think it's connected with the ATTCs, And people who work there are focusing on working with the opioid crisis. So they did some work also called From Stigma to Affirmation in 2019. And again, as I said, these are public domain, meaning if you're a trainer or you want to use these, you can. So what are the goals of this course? Let me say too, before I go on, if I ask you a question and you don't feel comfortable asking it, you don't have to. I know there's a number of people here, and I'm sure that people will be answering. So only answer what you're comfortable with. But what we'll talk about in terms of the goals is to increase knowledge about stigma and discrimination and ways to combat them, at least in the next 2 hours. We'll also look at language for probably the last part of the webinar, and we'll look at the language that people use around substance use, mental illness, and HIV and AIDS. And I was saying, those are the disabilities, by the way, that have the highest stigmas. And one of the reasons there's high stigma around them is because people blame you for getting them. And so it's interesting that in terms of disabilities, people don't usually blame people who are in a wheelchair for not walking, but take substance use, mental illness, and HIV, and people really may be judgmental about it. And that's when the language comes out. So it's something to think about. So what are the objectives? We'll define stigma, and we'll also look at types of stigma. We'll also define discrimination. We'll reflect on the impact of stigma, both personally and professionally. You'll have some time, I think in fact, I know I'm going to do an exercise pretty shortly for you to think about the impact of stigma. Sometimes too, when you go to a training, you think about it afterwards, but to look on maybe the impact of stigma in your own lives or the impact of how you've stigmatized other people, I think it's part of the process. And then we'll look at stigmatizing language, behavior, and institutional practice. I think the important thing, and you kind of know this, is that language influences behavior, and that's why I think it's important for you to look at the words that you use, because the words that you use will influence your behavior ultimately. You know, it's just it's kind of interesting these days that I use a sports example because I'm a sport person. And there was a coach at one of the colleges, and he was talking to his players after a game, and he is white. Most of his players are African American, and he used the word plantation. I think he said to them, "You got to stay on the plantation." And when I heard that, you know, of course, like you kind of think, what was he thinking? Why did he say that? Where did that come from? And of course, when people apologize, they'll always say things like, "I don't know where it came from. It wasn't part of my vocabulary." And I'm going to say that and this is my view, not the view of the ATTC, that sometimes when people use language to others, there's a good chance that they use it privately. Anyway, I think they've worked it out. He was, I think, suspended for one game. His players stood up for him, but every time you watch the news, there's always something going on around language. So here's what I'm going to ask you to do. All right, everybody ready? I'm going to ask you to think about someone who saw the best in you. Think about someone who saw the best in you. It can be a family member. It can be a teacher. It can be a mentor. It could be anybody in your whole life who saw the best in you. So what I'm going to do, and I see people writing in. You don't have to write in just yet, because I'm going to give you some questions on the next slide. All right, everybody ready? Everybody's got somebody? So here's the questions for you to think about and think about to reflect. And I was purposely focused, by the way, on an affirming experience, but who is that person, or what was the situation? What made it positive for you? How did they communicate that they saw the best in you? And how did you feel before, during, or after your time with this person? And we'll hold that last question. How might this apply to the topic of stigma? So as some of you are writing in, for example, your mother, your parents, your spouse, if, thanks Judith for writing in, so your mother communicated with love and forgiveness. So if people want to just think out loud or type in, you can put who the person was, and also what did they do? What did they say that you knew that they saw the best in you? So I'm going to hold on as people are writing. Unconditional acceptance. Thank you. Right, I see parents, spouse, and children. Again, I'll throw out the question is, what did they do? They gave you positive affirmation. Thanks, Anthony. Sincerity. Thanks, William. Unconditional love and support. Thanks, Wilfred. Oh, my boys, hugs and love. Heard me and reframe the negative self-thought. Thank you. Thanks, Brittany. Positive affirmations, love and support. Thanks for writing those in. Oh, thanks, Marietta. That is a wonderful compliment. And my colleague, Paul Warren, it's interesting because I think, sometimes when you work, you don't always know how you're helping people, and then people thank you later on. So you're welcome. Support, reinforcing my confidence, encouragement. All right, Nina has written a lot. Mom, the situation was grad school, feeling dismissed. She spoke power to the situation, that I can overcome the situation. And I know all of you can read, and I think most of you can see the chat, but I will read some things because I've been told that sometimes people can't see them. I was ready to give up and transfer to another college, a predominantly Black institution, and she said no. I was at a predominantly white institution. I stayed and obtained a doctorate. Congrats. Welcoming, smiling, always appeared glad to spend time with me, listened and interested. Thanks, Laura. Always encouraged me that I can do it, work harder. Thanks, Beverly. So as you think about that, one of the reasons I put this in, and actually in the day-long training where we work on stigma, we actually start with this situation, and then we usually go to somebody who didn't see the best in you. And the reason I don't do that for this course is, one, it's a webinar and it's 2 hours, and my job is also to create safety for people. And so sometimes when I ask questions that might really trigger you, I can't really follow through on that. But think, for example, and I have examples of people who were told when they were young that they couldn't do what they thought they could. So for example, Michelle Obama when she went to her guidance counselor in 10th grade, her guidance counselor said, I don't think you are Princeton material. Now, as many people know, and if you read the book Becoming, she did go on to Princeton and obviously to law school. So as the principal of that school says now, oh, that guidance counselor doesn't work here anymore. Okay, I'm just reading what people are writing. Encourage me. Okay, Nina has written, for me, it applied because as one of the few Black students, I was treated like I didn't belong. And that is actually an example of what would happen. And we'll talk about that more as we go along, so that sometimes if a person, if you're, let's say you're, as you said, one of the few Black students, and the teacher or whoever is working with you thinks that you, quote, don't belong, that obviously is stigmatizing, and that kind of stuff stays with people. So as I said, Michelle Obama was told she wasn't Princeton material. Oprah was told she was unfit for TV. Lady Gaga was told that she was not marketable. And I started to kind of look into probably some rappers or some performers who are probably more current than those, depending on your age. But I couldn't find particular information on that. But it really speaks to, again, of what you can do to help people, and also what happens when it's the opposite. So thanks again for sharing that. And that probably starts to, thanks Nina, it starts to answer the question about how might this apply to the topic of stigma, so that if you, a person, and you, many of you saw that list, saw people who were, oh, I was told the universe made me perfectly. Kevin, that's pretty cool. And it speaks to, again, of some of those things stay with you, whether they're positive, and some of those things stay with you when you are negative. So let's go to the next slide. And when you look at really what is stigma, you know, again, we throw around a lot of terms. So I wanted to kind of break them up and even look at the history of the word. So here's some examples. So stigma is a mark of disgrace associated with a particular circumstance, quality, or person. The second one, I got the first one actually because it was more recent. The second one, and this was written by somebody obviously in 1963, and who was in was worked as a counselor, that stigma is an attribute that links a person to an undesirable stereotype, leading other people to reduce the bearer from a whole and usual person to a tainted, discounted one. That is pretty painful. Social stigma is disapproval of a person based on socially characteristic grounds that are perceived and serve to distinguish them from other members of a society. Just in case if you want to look at kind of the history of the word, that the word comes from the Greek, and in Greece, ancient Greece, it meant branding. And so it was a mark or a puncture. And so, for example, throughout the history of slavery, people who were slaves were branded. In the 1590s, they also made a mark on the skin of people by burning. So it was an example. And the piece around stigma, by the way, could be for a variety of things. I mean, lately we've been talking a lot in the news and in the world about race, ethnicity, and equality, equity, but also, sorry, there goes the fire engines again. I don't know if you can hear them as loud as I can, but sorry about that. But Goff also talks about almost the stigma. For example, there's a lot of people who have physical illnesses, like people who are obese are stigmatized. People who have scars are stigmatized. So some of that kind of goes to those definitions. Oh, you don't hear the fire engines. Okay, cool. Thanks, Laura. All right, so here's another one, and this may come up as to what people were talking about, and it's almost the difference between or feeling different and feeling stigmatized. So it's interesting because they have all of those like blue balls in there, and they have faces that are like in frowns, and the person who's different, who's yellow, has a smile. So I was thinking of examples, and actually you can write in examples where you could think about this, but sometimes, for example, a person is like the only one, like for the person who is talking about being the only Black student at a white college. Sometimes it's within a family. So a person who is gay in a family may be the only person, or a person who has a disability may be the only person in their family who has it. So I'm going to throw out a question. What do you think about feeling different versus feeling stigmatized? What comes up for you? You know, that's kind of a loaded question, but what comes up for you when you think about feeling different versus feeling stigmatized? If you just, anybody wants to write in. You know, it's a tricky one, I think, to think about. I may actually go to the next slide, and here's just something to keep in mind about, quote, different. And it's like, what makes the feeling of being different either neutral, positive, or negative? So sometimes being different can be a positive thing. Sometimes being different can be a negative thing. Yeah, thanks. Actually, people have written in, so let's read what people have written. Learning to deal with the personal emotions. Thank you to negative self-image. Different is personal inside. Stigmatizing is coming from outside sources. Thanks, Catherine. Tiffany writes, feeling different feels like my opinion of myself, while stigmatized is what others have made me feel. You know, and that's interesting because we'll talk about sometimes internalized stigma. And where does internalized stigma come? Probably from outside. And as Brittany writes, depending on the developmental stage, feeling different can be a badge of honor. Yes, so depending on who we are, and sometimes some adolescents like to be different. On the other hand, sometimes they don't. So it's just something I think to think about. I was had written down like the example of Serena Williams, and she's married to a white man named Alexis Ohanian, and he used to be the head of Reddit. So obviously he is a man of privilege. And what he was saying too is that for him, he often went into situations where he was, quote, different, but he was the white male walking into a situation of being different. So he always felt like he could be part of something. On the other hand, Serena Williams has had to deal with situations where she has walked into meetings or tennis courts where she is seen as being different because of her race. And there's probably a lot that she has gone through in her life, as well as her sister, of being African Americans in a white sport. So the whole difference, it kind of, one of my trainer answers are, it can really depend. So what makes different stigmatizing? And it's almost like there's like micro versus macro. So individually, it can cause negative judgment. Actually, those are things that some of you wrote in: a lost opportunity, fear for self or others, and violence. So for example, I was just working on another program where we were talking about trauma and LGBT people, and we were looking at some of the examples where many times if you ask a young person who is identified as gay or is perceived as gay, they were often beat up as a child or kicked out of the house, again, because they were, quote, different. You can't see me, but I think what I'm doing is I'm like acting out what it would be like to have quotations, but you can see that on the slide. In larger societies, so other people like you have similar experiences. Negative stereotypes about people who resemble you are widespread. People who you identify with are experiencing negative consequences. And I don't have to say, for many of you, you know exactly what that means. So, and this kind of came up in some of the chat, but some more information around stigma is the internal experience and becomes internalized. And what do people sometimes feel? They feel shame. They feel self-conscious. They blame themselves. It reduces their self-worth. And as the experience is repeated, it can be more and more intense. And as I said before, it's manifested in many ways. So it's physically, like somebody could get beat up. Socially, people are not accepted or not invited to places. Yeah, so thanks as people are writing in. Let me just finish this thing about institutionally, we'll talk about that as well. So I'm going to read some of these, by the way. Start with Tiffany, feeling different feels like my opinion of myself, while stigmatized is what others have made me feel. Brittany, yeah, actually, I read that before. And Joyce writes, it depends. One can feel lesser or greater than. Joan writes, sometimes it's me and how I feel about myself. And James, thanks for writing, teenagers gang up on others to fit in. So for those of you who work with adolescents, you're kind of familiar with, or actually as we have all gone through adolescence, some of us more recently than others, about what that means about fitting in. All right, so there is a circle of stigma. And again, this comes from the AIDS Institute course. And do you know how sometimes in some courses you've seen the term intersectionality? And so I think it speaks to, there's a real whole circle of stigma, and I'll go over them, what they mean separately, but actually they often are combined. So let's look at the top first. So internalized stigma, a person's belief that they are less than. You know, where do people get that? Sometimes people are told that. Sometimes people watch television and they don't see people who look like them on television. So you get kind of a sense of, quote, less than. Anticipated stigma, a person expects to be stigmatized. So sometimes word on the street, or if people in families have gone through, let's say, discrimination. And stigma, by the way, is often the belief. Discrimination is the action. So the action is often a result of the belief. But sometimes if people expect to be stigmatized, that's part, they still feel the same emotions that people might experience. Vicarious stigma, a person does not experience it but fears it. And, you know, for many people to kind of live in fear of being stigmatized or being discriminated against is really can be very difficult for people. And then enacted stigma, a person has experienced stigma or discrimination. And so sometimes it's kind of that circle, the intersectionality. And when you think about intersectionality, you can look at, for example, the person who uses substances as one. The intersectionality also might deal with things like economic background. So people who are poor are stigmatized. I remember doing a lot of trainings in welfare offices, actually throughout New York and throughout Connecticut. And what came up often was sometimes people, and I'm not, by the way, there are good people who work in welfare offices, and it's like anything, and there are people who probably shouldn't be working in them, and that's my opinion as a voc rehab counselor. But sometimes people didn't like working with people who were poor, but that's what they did. And could people feel that? You bet. Sometimes people would act like it was their own personal money they were giving to people. And these are examples of what clients have told me in the past. So let's see, Paul's written, how does one deal with stigmatization when it's part of their conditioning and the world they live in? That is a good question. And you know what, if you want to, I could, can you hold on to that, Paul, or remind me of, at the end of how does one deal with stigmatization? Can you hold on to that and remind me again, and we'll edit, we'll throw it out to the group. Thank you. So just to kind of continue, as I said, stigma is the belief, but it results in discrimination. And so it's feeling different and feeling stigmatized are distinguished by the presence of societal forces. And I don't have to tell people here that many of people are dealing with being labeled, being stereotyped, being separated, losing their status, the loss of opportunity. So they are definitely connected. And this is kind of the working definition of discrimination. the unjust or prejudicial treatment of people due to membership in a particular group. Think about it, for example, for people of color. If you look, for example, at corporations and you look at who's the head of the corporations, how many people of color do you see? And that's I'm kind of throwing that out as a question is, you don't really see a lot of, actually, there also are not women in some of these as well. How many women are in the Senate? I didn't count that, by the way. And I know that there have been more women elected to the House in the past elections, but the numbers are still very low. Here's another example for sports fans. How many African American head coaches are there in the NFL? So the National Football League has mainly most of the players are African American, and maybe there are about 4 head coaches. What's that about? If you look at the NBA, the National Basketball Association, same thing. And I know they keep talking about it on a lot of on ESPN or what needs to change. And certainly this has been in the news, and we've been talking about it, but the numbers again are still dismal. They're worse than they used to be. So to kind of go on around stigma and trauma, and many of you have taken courses on stigma and trauma, or trauma-informed care. And just to be aware that the experience of stigma is often traumatic. And I'm going to say the good news is that people can recover from trauma, but just going back to the trauma, it can cause physical, emotional, and mental effects. And personal resiliency promotes recovery. There have been some webinars that have been given by the people at NISP, the New York Psychiatric Institute, where our offices are, and they're talking a lot about resiliency, especially around COVID. And what they just said, and I think this may be helpful to people, is that resiliency really is about bouncing back. But they also stated and wanted to make sure that resiliency is a process. So depending on where you are and how you're feeling in the midst of this pandemic, ideally people will get back to quote normal, although they'll get back to feeling better. But you don't have to wake up tomorrow and say, guess what, I'm better, everything is fine, and I'm resilient. So just to be aware that resiliency is a process. So going back to some of the long-term responses of trauma, and these are some possible ones. So that for some people, many of our clients are dealing with post-traumatic stress disorder for a variety of other reasons. And we also want to look at the possible long-term responses of resilience. And what happens is unresolved trauma and the impact of trauma persists and can worsen. So actually, before I go on to, let me do one more slide and I'll go back to, I think it was Paul's question. If you haven't read anything by William White, he is an advocate in substance use, and he wrote the book Slaying the Dragon: The History of Addiction Treatment and Recovery in America. It's a really fascinating book, and I happen to own it, and I like to read it and find out what was going on at different times. And I wanted to put this information, especially because the stigma about women who use substances is often greater than men who use substances. And here's a couple of things he said, and when he was looking at kind of the history, is that stigma and shame shaped the nature of treatment for women, and that treatment programs for women were started in 1841. As you look at that date, by the way, obviously it was pre-Civil War. So that tells you who went into treatment. But one doctor thought that drinking ale would help with nursing. So if a woman was nursing her child, it was recommended that she drink ale. Now, I'm not telling you how to do that, by the way, or I'm not suggesting that. I'm just sharing with that was kind of common knowledge. And actually, when men and women were in treatment, they were separated, which also makes sense. But the reason they were separated was, to quote, to protect the men. So the people who were running the treatment centers thought, oh, if women are around, this is going to ruin the men. Yeah, thanks, William. It is a great book, and it's a must. Thank you. It's a must read for anyone in the substance abuse field. Oh yeah, and so Wilfred, you're saying not true about the ale and about separated in treatment. So I guess to the person who had the question about, I'm kind of going back if I can see the question. Oh, actually, so Paul wrote the question, how does one deal with stigmatization when it's part of their conditioning and the world they live in? You want to give that a try before we get into some discussion around language? So the question is, I know this is a big one that if we were in person, we could talk about, or I could break into groups, but we won't do that, or I can't do that. But how does one deal with stigmatization when it's part of their conditioning and the world they live in? And Paul, if you want to add more to that of what you meant by that. So it really had to do with, if you can't hear, by the way, Clyde will help you. And, you know, unless nobody can hear, then I know it's me. So do people, let me go back to the question. And if anybody wants to write in, as you remember and the question again was, how does one deal with stigmatization when it's part of their conditioning and the world they live in? How does one deal with stigmatization when it's part of their conditioning and the world they live in? So as Paul wrote, Black people in America are extremely resilient, have dealt with some trauma effectively, and still have a great amount of trauma not dealt with. Absolutely. And, you know, when you think about that, you know, you've heard the term minority treatment, a minority trauma, so that for some people just going out on the street can be traumatic. And so, yeah, it's like this fine line between, yes, people are resilient, and there still is a lot of trauma that has not been dealt with. And, you know, what do we do with that? I'm going to say, you know, if you know, my colleague Diana Padilla has been doing a lot of work and courses on implicit bias. And so if you can take courses in that, I think that is helpful. You know, I was using an example the other day about, remember there was the gentleman who was a bird watcher, and he was in Central Park, he's African American, and he was kind of accosted by a woman who was afraid of him, and she called the police. And when he was being interviewed, he was saying that he purposely wears glasses so that when he goes out, he looks nerdy and he won't be a target. And for many people who are not of color, those are not things you have to think about when you go out, of what that danger is. Like if you're just driving somewhere, driving while Black, those are, again, when you look at what many people have dealt with. And I think for all of us to really and actually as Anne's writing, be an advocate for yourself and others, help educate others, you know, about addiction and disabilities. Thanks, Judith, with courage and boldness. I like that. For stressors, it helps to have healthy outlets and a support system, friends, family members, like-minded individuals working to make things better. Yeah, and women of color deal with stigma regularly in many facets. And I think just to kind of to validate that there are many again, traumas as a result of race that some people don't have to deal with. And as Brittany writes, I wonder if part of the answer to the question about stigmatization is examining internalized cultural beliefs, examining core beliefs, and challenging automatic thoughts. And I will say to that, yes, yes, and yes, because I think it speaks to, again, for everybody, internalizing or getting in touch with your own stuff. What are your own cultural beliefs? And working them through if you need to, because those beliefs will come out in how you work with people. So to keep examining them and always, to look at them and then challenging yourself. I have some examples later on about language, about what do you do when people are at your site and they're using language you're not comfortable with. So I will kind of come back to that. So I might be dating myself with this saying, but when I was growing up, there was a term that says, sticks and stones may break my bones, but names will never hurt me. So yes, names do hurt. Yes, the stigmatization of anyone affects everyone, absolutely. People don't always get that, but yes, that is true. So anybody else, what do you think of the expression? I think names do hurt. Yeah. Oh, you grew up, Nina, thanks. You grew up saying that expression. They hurt as well. Definitely. And I don't know if you grew up and like that's what your parents told you to tell people when people were calling you names. I think one of the challenges was to kind of get over it, but also it kind of, so many of our people have been verbally abused, and the pain and trauma from that is very great as well. Oh yeah, so if people are talking about your nationality, that's when you felt the pain of the words. Thank you again for sharing that. Words hurt and destroy people. Yeah, you condition yourself to not be hurt, but it kind of goes back to, I think, what either you were saying or people were saying, is that there's a lot of trauma that goes on that people don't see because you kind of have to suck it up, but in reality, it's very damaging. Yeah, it is about power. Sticks and stones hurt physically, but names hurt emotionally and mentally. So thanks, Anthony. I'll actually go to the next slide on that one. Yeah, it leads to trauma. The challenge, by the way, with that is that sometimes professionals, but maybe not everybody, but sometimes when people look about, like if somebody came to you and they're talking about being called like names, sometimes people think, oh, that's not as bad as getting beat up, or you look for people sometimes if you're looking for black and blue marks, but again, I think there's the verbal abuse is like black and blue marks that you can't see outside on your body, but actually they are traumatic. And for some people, it's part of the whole trauma that they experience. For some people, that's what they do, that they deal with. So just to kind of segue to some of the stereotypes of SUD, substance use disorder, impact, practice, and policy. This comes from Dr. Dole. And if you work in, yeah, emotional scars are internalized. Absolutely. Thanks on that, Joyce. If you work in methadone, you probably have heard of Dr. Dole's. And sorry, I'm just reading as you're going on, but I'll encourage people to kind of look in the chat as you see at people writing in. Dr. Dole was one of the kind of the gurus of methadone treatment in New York, and he and Drs. Nicewinder, who happened to be, by the way, his second wife, started some of the programs in New York City on methadone. And what he said was that for him, I'll read it. You can kind of read along with me. But for me, the most educational experience of the past 3 decades was to learn that the traditional image of the addict, parenthesis, weak character, hedonistic, unreliable, depraved, and dangerous, is totally false. This myth, believed by the majority of the medical profession and the general public, has distorted public policy for 70 years. So he wrote that. He actually said that Dr. Neiswinder really helped him in working that through. So, oh, I just lost my slides, Clyde. Closed. Sorry about that. I just lost my slides. I'm coming back. Sorry, I'm still here trying to get my slides back. I don't know if you could still see some of my slides. Oh, hit escape. Reopen and share. So if I hit share, sorry about that. I just made a mistake. I'm going to have to close and I'm going to open up in a moment. Oh, man. Oh, gosh. Okay. Sorry, I'm messing up. Let me look for my slides again. Oh my gosh. Hey, Clyde, sorry, stop sharing. You know what? I apologize, everybody. I am messing up. Let me look for my slides again. Am I back? Okay, so I'm back, I hope. Sorry about that, everybody. All right, moving on. Let me open up those slides again. Okay, I'm not Clyde.
You've got the wrong window opened up. Too many windows are open up on the screen, so you can close out windows that you're not using on your screen, and then that way you can
Okay.
spread out the slides.
How do I do that?
X out on the windows that you got. If you look at it, lower the screen and just X out on the windows that you got open. Right corner, top right corner.
Yeah, I don't see anything in the right corner.
Bring down the entire. You're sharing the wrong window. That's why the wrong window. When you hit the
Okay.
share screen button, you will see several windows. If you've got programs open, then you gotta choose the right program with this, that shows the PowerPoint story, the PowerPoint application, and that way that's what we're sharing. Right now, you're sharing some part of the desktop with the
Oh,
greeting.
you know what? Actually, Tree said that she can share, you can make her the host and she can share the slides.
Okay,
How's
okay,
that?
that's fine. That's fine.
All right. Okay, everybody, I am really sorry about that. What'll happen is, luckily Clyde is helping me out with this and Tree Chapel. So what I'm gonna do is, Tree will be working, the slides. And when I started to mess up, we were talking about Drs. Dole and Dr. Neithwander. And then we went to the slide on the power of words. So can you see that?
No, how's she gonna share the slides?
Say it again. Yeah, Tree said that she could be the host and presenter.
Can she?
Okay, can you do that?
Okay, hold on there.
Okay, thanks, Tree. If you would go on to where it says the power of words. Thank you so much. Again, I really apologize. I don't know what I did, but I did mess up on something. So, as we were saying, that this was that book, this is a picture of Dr. William White, and what he says is that words have immense power to wound or heal. The right words catalyze personal transformation and offer invitations to citizenship and community service. The wrong words stigmatize and disempower. One of the reasons I thought that was interesting too is because sometimes, I was talking examples of when like Michelle Obama was told that she wasn't Princeton material. And actually, so what did she do? She did the opposite. So sometimes when people are told things, they go to prove others wrong. So next slide, please. Tree, can you go to the next slide? So the question is, and actually it's the one before that, so what if we treated other diseases the way we treat substance use disorder? And then if you go to the next slide. So think about this. You go to the hospital with chest pain and you're found to be having a heart attack. And what if you went into the emergency room and you were told it's your fault because of your choices, or you were denied treatment because you did it to yourself, or you were given a list of cardiologists and cath labs to call, or you were only given aspirin if you agree to go to counseling, or you were kicked out of the hospital for more chest pain. So what do you think about that? If you want to just write in as you read those kinds of things, and there's always a method to why we do this, but what he was saying is that if you were treated the way sometimes people with substance use disorder are treated, then that would certainly affect, how you might be dealing with. Okay. So any reactions to that? If you would just want to type in. And I can't really see my chat, but let me go on. If you would go on to the next slide. So thanks, Tree. When you think about the languages that are used for people with other illnesses, look at these words of when people are dealing with other illnesses. So you'll hear words like fighter, he suffers, survivor, patient, endures. And again, sometimes the language is affected by or influenced by the cause of the illness. And that's what I was saying before. For some people get blamed for having substance use. People get blamed for having mental disorders. When you hear somebody say to somebody who's depressed, who's clinically depressed, I don't know what's wrong with you. It's just, what's wrong with you? Why can't you just get up and think of all the things that you have going for you? So I think, again, we can, looking at stigma and language, it can be used really in a negative way. Next slide. So the language that's used for people with substance use disorder, and you'll see, for example, it's a big thing about clean versus dirty. When people are talking about clean urines, dirty urines, and we'll talk later on about maybe some of the words that you can use too. some of the words that you can use to avoid some of the stigma in terms of language. And when the DSM was coming about, and yes, I can see the chat, which is good. So yeah, as Wilfred writes, addicts are viewed as weak people. Society will never view addiction as an illness. And you know, that's kind of the challenge of kind of the moral model. Remember, he studied about the moral model, like in Substance Use 101, that often people do believe that people who use drugs are bad or evil. So the key for us, and this kind of goes to some of the questions that we look at later on, is what's the language that we use and how do we change it? So if you go to the next slide, please. And as many of you know, the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, took out the term abuse. Remember, we used to always have to study, like, what's the difference between abuse and dependence? But they took it out really to take away some of the stigma, and that's why they changed it to use. And you can see, by the way, that if you look abuse up in the dictionary, it's derived from the word meaning wicked act or practice, a shameful thing, a violation of decency, associated with behavior such as rape, domestic violence, and child molestation. And so it really speaks to, again, that professionals are more likely to view the patient as deserving of punishment. So when you think about, for example, sometimes somebody goes to a doctor and they've been using substances and the doctor doesn't believe in the addiction as a disease, they may be talking about kind of blaming the person for getting that. Okay, so sometimes it's helpful to really kind of take that out. Next slide, please. So lots of stigma for substance use disorder. And I know we've talked about this around, you know, what's the stigma from within. So as people, I think, mentioned that before, is that, you know, and people come to treatment, often they blame themselves, they feel hopeless. And we have to be careful with that because we don't want to, we want to validate their feelings, not of feeling hopeless or blaming themselves, but we want to use the language that we use to make them feel like there is going to be hope. Yeah, and actually, thanks, Wilfred, as you were writing in, that's where the stigma comes from. Yeah, society is judgmental. You know, they are. I'm stuttering in a sense because sometimes they still are, but it kind of looks like, what do we do? Actually, what do we do to perpetuate that? And that's why we can look at the words. It's like the person who uses substances. I mean, another thing too is that there's a lot of stigma from the recovery community. So when people talk about medications versus abstinence, and I know, for example, with, let's say for Alcoholics Anonymous, as an example, that people are told, the official word is that if you are on medication, such as, let's say, antidepressants, and it's given to you by a doctor, that you can take it, but it's still viewed as, even today, as Joan writes, it's still viewed as a moral issue among populations. So sometimes, for example, if somebody is on, for those of you who work in methadone, you know that sometimes people started Methadone Anonymous, their own groups, because people on methadone were not welcomed or allowed to share in NA meetings or AA meetings. So there still is that whole piece. Is it getting better? I'm not sure. Some of you would know that better than I. Stigma from clinicians? Yeah, it is still. Oh, so yes, Joan, so it's getting better. That's good to hear. So I think there's stigma from clinicians that people don't believe that treatment is effective. And, oh yeah, as Wilfred writes, they're welcome in AA, but not NA. So officially, we know what the word is, but in reality, it might not happen. I was thinking, for example, of, some of you may have heard me use this example, but I guess like 8 years ago, my husband was sick and he was dealing with liver cancer. And so we were dealing with a lot of hepatologists and also people who were working with the hepatologists. Ironically enough, it was at Columbia Hospital. And when I met a lot of the residents who were working there, I would tell them, you know, and they were in treatment, or I mean, they were learning how to be, quote, a doctor. And and when I told them that my husband had been in recovery for 30 years, they said that they couldn't believe it. They said they never met anybody who was in recovery for that long. They didn't know it could work. And my thoughts at the time were like, you're going to be a hepatologist, you're going to be a liver doctor, and you don't believe that treatment is effective? So I felt compelled to educate them, or to share my experience, strength, or hope, or my husband's experience, strength, or hope on that. And then again, the stigma from outside, and some of you have written this as part of the moral model, is it a choice versus a disease? So sometimes people say, well, she chose to use those drugs, that's why she got it. You know, that's why she ended up where she ended up, as opposed to that person has a disease. And it doesn't mean, by the way, that the person didn't, one, choose to start using a drug, but what happened is for some people, that when they start using, they can't stop. And that's where a lot of the disease model comes in. Next slide, please. So here's just some more examples. Is people with substance use disorder and those on agonist therapy may not be accepted to post-acute care facilities. And so that really sometimes prevents people from going to different kinds of rehabs, like physical rehabs, if they don't accept people on agonist therapy. And what that means, by the way, is people who are on methadone or people who are on buprenorphine. And for example, it says on the second bullet that people on agonist therapy may not be offered organ transplantation. Now, I've looked this up in different hospitals, and what many places say is that they do offer transplantation to people on agonist therapy. So their literature says they do, but that in real life they don't. So I think that's important to kind of look at. And also people mandated to treatment as a condition of probation who have a positive toxicology despite treatment adherence can be imprisoned. So, you know, when people have the choice between going to treatment or going to jail, you know, what are the, you know, what do we do with that? Thanks as people are writing in, my colleagues are quite biased to subs. Yeah, you know, it's interesting too, because depending on where you work, there still is a lot of bias about people who are using substances. And some of you obviously are in treatment agencies where you would hope that people wouldn't, but that doesn't necessarily mean that people do. Next slide, please. So continuing on the impact of stigma, it erodes confidence that substance use disorder is a valid and treatable health condition. So if you don't believe that, oh yeah, it seems like people are writing in that you do work with people who are biased towards people who use drugs. So I guess if you don't believe it's treatable, then that is going to be a challenge. It certainly is a barrier to jobs, housing, or relationships. The interesting thing too, though, is that for most people who are using substances, they are already employed. So it's sometimes the impact of stigma. One of the things too, like from a jobs point of view, is that the ADA, the American with Disabilities Act, protects people who are in recovery. But the challenge is that if an employer is interviewing like 50 or 100 people, and for some reason they find out that the person has been using drugs, they can just hire somebody else and they won't get sued for it. But it's just something that really, again, becomes challenging. It deters public from wanting to pay for treatment, allows insurers to restrict coverage. Remember when buprenorphine first came out and was being prescribed, there was a whole, I think the insurance companies were really looking at, one, how much is it going to cost? They felt like it was, in a sense, more cost effective than methadone. They also wanted to know how long people would quote have to be on it. And now they have been, I think, more open to that. And as they see that actually buprenorphine has been shown to work, ultimately it is good for the insurance company as well. But that kind of thing will actually stop people from seeking help, and again, impacts any kind of decisions. Yeah, I'm just reading what people have written. So Wilford writes, sometimes the recovering professional has their own biases and has a difficult time with the recidivism population, or people who use again. Yeah, many of you have heard me say this before, but I think it's important to really get in touch with your own stuff. And whether you're in recovery or not, sometimes you may have certain feelings, or you may have countertransference about somebody who's using. But it's important, really, I think, for your own health to get in touch with that, because it will make you keep you healthier. And in these days when self-care is really necessary, and you're dealing with people you don't like, or people you don't want to be with, I think from a voc rehab point of view, I might say it's time to get another job. I used to always remember sometimes when I was doing trainings in person where I'd meet people who worked in methadone clinics, and then when I'd talk to them during the breaks, they'd say they hated methadone, or they didn't like that people were on methadone, or they went to work there so that they could get people off. And yeah, I agree. Thanks, Monica. Yeah, they need another job. I remember once I called up an agency, and I don't know if this was with SAMHSA, but it was one of those. I was trying to find out more information about buprenorphine. So I called up, and actually I was online, and they say, well, why do you want this information? So I type in, I'm training a course, I'd like to get more information about it. And so the person who was on the line started sending me more information, but then he writes like a PS, make sure you tell the people in your training not to use buprenorphine. And I kind of went, oh my gosh, do I report this? And it was from an agency, and I don't know if it was NIDA or SAMHSA, but it was somebody who probably shouldn't have been writing that. So yeah, everybody, people may be dealing with their stuff. Again, important to kind of look at that. All right, next slide, please. So we'll be spending actually the rest of the time, hopefully, looking at language. And some of the things that have been kind of looked at is, if you look at a language audit, which is like looking at the materials that you have and look for words that are stigmatizing and then replace them with more inclusive language. So for example, Oasis has changed their name. So a lot of agencies have changed their names to reflect the change towards substance use. I think we might have we have a couple people here from SUCAP, which used to be called SACAP, which used to be called substance abuse. Now it's SU. So that was done purposefully and that's actually a good example of doing a language audit to kind of look at stuff. Because, sometimes we'll teach this stuff and then you go back and you look at what materials you're giving out or what you're using, and the language that has been used is really kind of shows the bias, or doesn't show, again, the person-centered feeling that we want to talk about. One of the examples, by the way, you can use search and replace functions for electronic documents. You search for the word addict and replace it with a person with substance use disorder, or change abuse to use and misuse. I mean, that's an easy way to kind of change that. In the DSM-5, by the way, they don't use the term addict. They use the person who's using substances. And I know some of you, by the way, if I've spoken to people about, if you're in NA and you introduce yourself as, hi, my name is, and I'm an addict, and people said to me, do you think people should change that? And I said, I don't know the answer to that. There is a purpose for that, but I think just to kind of look at your jobs, what you can change. Yeah, and as Wilford writing in, thanks for writing in, by the way. So in our biopsychosocial, there's a question, what are your strengths? Then they ask about weaknesses. Yeah, and you don't like the word weaknesses. Sometimes when I change the word weaknesses, I change it to challenges. I kind of play with it as well. It's like the word character defects in the 12 steps. One of the challenges I have for the term character defects is that to me, a defect sounds like something you can't change, whereas a challenge or a barrier you can. So the language audit is really, and this comes from SAMHSA, by the way. Yeah, areas that need to be improved. Yeah, or I also use the term improvement opportunities. Yeah, areas for growth, barriers. I think, thanks. Those are all really good examples of, like, quote, changing weaknesses to areas for growth or barriers. And the reality, by the way, is that many people who have used substances come with many strengths. And if we talk about those first, it can be really helpful to having people kind of change their concept of themselves. So language can do that. So next slide, please. So here's some ways to, there's some words to kind of play with. So to avoid the term dirty, clean, abuse, and abuser. And I know some of you might be thinking, no, but that's the way we've always used it, and I'm going to keep using it. And you know what? That's okay. But it is interesting that we use the term dirty or clean. The term also, dirty or clean, is often used in HIV. It's often used for people who are living with HIV when you're talking about pejorative terms. I'll give you an example. A friend of mine who's been living with AIDS for many years said he went on Grindr, the app. He said he went on the app just to see what people were asking for. And it's an app where usually men go there to have sex with other men. And what he said was, when he was reading the descriptions, that somebody would say they want somebody who is, quote, clean. And what they meant was they wanted somebody who didn't have HIV. But his whole thing, and I think he wrote this back to the person, is, I'm clean. I took a shower this morning. So just think about the words that are used around that. Another thing, and actually a lot of people disagree with this, but consider changing medication-assisted treatment. And I know we talk about MAT all the time, but that medications for addiction treatment are life-saving. They're similar to insulin for diabetes, and we don't call it insulin-assisted treatment. So a lot of people don't like that, by the way. I remember doing a training on methamphetamines, and it came up in an issue in some of the breakout rooms. But I'll just throw it out to, these are things to think about. Medically supervised withdrawal is also more accurate and less stigmatizing than detox. So medically supervised withdrawal. So I don't know what people think about that, but it's something to keep in mind. Thanks. Next slide, please. So HIV and mental disorders. In addition to substance use, HIV and mental health disorders also have high stigma. And I've said this a few times already, that people blame you for getting them. And so sometimes the language around that is also pejorative. And the language used for each disability has the power to stigmatize a person. I remember when we used to do trainings on sensitivity around mental health, we would sometimes we'd actually ask people to write on those whiteboards, what are some of the terms that are used for people with mental disorders? And I mean, you know what they are. And I don't even like to say them like anymore, but I will tell an example. I used to work at Gracie Square Hospital, and I worked on the substance use unit and also worked on the unit for people with co-occurring disorders. And at the time it was called, and it still may be called, dual disorders. And so the people who were on that floor, the 5th floor, they sometimes referred to themselves as, quote, doolies, or when people on the substance use unit were acting out, people would say, yeah, you better not do that. They're going to move you to the top floor and you're going to be one of the doolies. And I share that because once I was doing a training and somebody came up to me and said during the break, you know what, I was one of those doolies. Thanks for how you helped me. So it just speaks to, again, of the language that was used, but I wouldn't, I'm giving that as an example, but I wouldn't use it right now. All right, next slide, please. So this is a true case study, by the way. And again, because of time, I may just ask you to kind of think about this because I have another exercise I'd like people to do. But this was a person's statement in the lunch area. So that new patient, Clara, she's an addict, and you know she's having sex with God knows how many people. I wasn't surprised when the test showed she is infected with HIV. And she has 3 children, and then she is supposed to be taken care of. At 23 years old, she's just a child herself. I will ask the question, by the way. Yeah, thanks for writing that in. Either any kind of reactions to that. Again, true stories, and also in the lunch area. So think about confidentiality, and also, I don't know about you, but sometimes although I haven't sat in a lunchroom for a really long time, but sometimes if people were sitting next to me when we were at Columbia and they were talking, you know, you couldn't not hear what they were talking about. So it's amazing that I don't have to make up stories like that. That wasn't from Columbia, by the way. It was from another source. But it's always like helpful, I think, to look at, you know, what do you, how do you talk? Next slide, please. So here's where we will do an exercise, and I will ask you to write in. You'll be getting copies of the slides, by the way, and if we don't have time to get to all of these, which we might not, but on the left-hand side are what we would call ouch words or phrases. And we may do a couple of them to find out what options do you think are more affirming. So actually, I'm going to keep it substance use related. So get clean, referring to substance use treatment. What would be a words? What could you say instead of that? Instead of he's going to get clean. Oh, he's going to get healthy. What else could you put in there? Of course, I have the trainer manual, so I could tell you the answer. Yeah, substance free. That's a good one. Embracing recovery. Thank you. I like that. Want me to tell you one of the answers that they say is just if you were saying getting treatment for substance use. So just it's really kind of changing that. How about the term drug user? Drug user. What could you say instead? Instead of saying he's a drug user, she's a drug user, what could you say? Anybody, if you want to just type in? Yeah, dependence. Anybody else? What could you do? Thanks, Monica. Yeah, the person with substance use disorder, and actually that's very similar to what's on the trainer manual answer. So it's always again, and we kind of I proselytize on this a lot, but the person with substance use disorder, it'll help you also. I mean, it'll help the client or the patient, but it'll help you also look at it will help you, I think, feel more comfortable with people if you look at them as a person first. So it could be a person with schizophrenia, a person with depression. Let's see, let's look at some others. Actually, promiscuous. Some of you have heard me proselytize about this for the past 10 years. I would say it's a word that I would encourage people to. Yeah, could you use the word patient? Yes, you could. You know what else? Sometimes people get into, are they a patient or client? I'm going to say, are they a consumer? I'm going to say it's going to depend on your agency. You know, sometimes if you're in a hospital, you're talking about patients. In agencies, you're talking about clients. In the field of mental health, they often look at consumers. Sometimes people who work with people who use drugs don't like that term, but Yeah, a recovery. There's a whole bunch of things that you can use with that. So, as I was saying, delete the word promiscuous from your vocabulary. And why do I say that? Because anybody, why do I say delete the word promiscuous from your vocabulary? And actually, you could tell us what you would put in instead. Yeah, okay, sex worker instead of prostitute, yes, which is also on there. I can tell you that the reason some of you have heard me say this many times is that the word promiscuous is usually it's a term that's pejorative, and it's often used to describe women, by the way, or gay men. It's never used as a word for a man. And what it means is that the person's sexually active, and there is no technical definition of what is promiscuous, of how many people you have to be with to get that definition, but it's just something, it kind of grates at me. I think I was with my family and we were talking about somebody in our family, and one of my brothers said, oh, she was so promiscuous. I just like jumped down his throat, and I don't always do that, but I thought, how could you be saying that, my brother? So just be aware that that word, although it's interesting because sometimes you'll ask a client something and then they'll say, well, I was promiscuous. So you have to figure out what you're going to do with that. Here's some other words. Actually, they have the word transgendered on the left-hand side. And I know that could be a whole nother course around LGBT issues and vocabulary, but what would be a better word for instead of transgendered? Anybody? You want to write that in? Yeah, actually, yes. Thanks, Brittany. Yeah, a transgender male or transgender female, that is an appropriate way of kind of explaining that. I know, so sometimes, people, they'll use the word like tranny, and that's, again, another one you don't want to use too, but it's as you said, a transgender male or a transgender female is explains kind of what that really means. Are there other words there that you would like to play with? How about injector? So if somebody is, quote, that's the noun, they're the injector, what could you say instead? Instead of injector, you could say, please write in. Right, one who uses intravenous drugs. Thanks, Ann, on that. It's kind of simple on that. One who uses drugs or a person who injects. And when you think about the noun versus the person who uses, kind of the connotation of that is makes it kind of like bad, or it kind of goes to the moral model. So thanks for writing that in. Let's see. How about illegal immigrant? Illegal immigrant. What would be another term that would be a better term to use than illegal immigrant? Anybody, if you want to write in? Yep, undocumented. Yes, definitely. A non-citizen. Thanks. And again, you could hear as you use the words, it could be a person born in another country. I just finished a book called The Last Frontier, and it was about two families who are refugees. And one of the reasons a friend of mine recommended that I read it was because the amount of traumas that people had experienced was just so overwhelming. And sometimes we see somebody and, we hear they're a refugee. And if you work in an agency that works with people who are refugees, you might not always realize the many, many traumas that they have experienced. So we don't want to kind of go on to that as well. All right, let's go to the next slide, please. So here's some strategies. And what this means, by the way, is suppose you're at a case conference and somebody starts using terms that you are not comfortable with. I think some of you, it could be the whole gamut of terms, by the way. Like, what do you do with that? I don't know if you were watching, I was watching television yesterday, and I don't want to get political, but I think Sharon Osbourne, who was on the show The Talk, she was defending Piers Morgan's attack on Meghan Markle. And the two other hosts were talking to her about, what it meant to be racist or to support somebody who's racist. You probably have to see the whole show, but it was one of those uncomfortable conversations which probably needed to happen. It probably was, I think, challenging for them that it happened on television while everything was live, but it spoke to, again, the conversations people often need to have. I haven't read the book by Emmanuel, I forgot his last name, the person who is a football player, and now he's going to be taking over on The Bachelor. And he wrote a book about having uncomfortable conversations. But anyway, so going back to some of the strategies, if you're with somebody, if you have a coworker, yeah, thanks, Joyce, it should be addressed at the time without hostility. And I think what it speaks to, by the way, is it's important to address it. But as number one said, avoid blaming or condemning the person as bad and focus on the specific behavior. So it's, for example, when you said this, I felt uncomfortable. And that's what we learn this a lot from Counseling 101, but calmly explain to the coworker or the person what you found troubling about what was said or done, being as specific as you can. So it's not saying like, you're a jerk and you're fill in the blank, but it's saying really specific, this is what you said. And also speaking from the I noticed that, or I felt that. And people can sometimes hear it if you say, I felt offended when you said, as opposed to saying, you stupid jerk, why did you say that? So another thing actually to look at too, and this whole piece about language, I mean, for ourselves, it's really important. I think for our clients it's important, but it's also important, I think, for our agencies too. So when possible, point out what was done and was not in accordance with agency policy. So you can always, again, go to agency policy about the language that you used. Next slide, please. So as kind of to follow through on that, you want to look at one of the reasons you're doing it also is to provide high quality service. And I think that's important as well. And sometimes you can always, if you observe something and you gave them feedback, check in with them, discuss with your supervisor. And it can also be important that language is spoken of at a staff meeting. And so you can also, if the client wants to file a formal grievance, you can help them with that or report the event yourself. So it's really taking ownership of what you saw and not just letting things slide. Next slide, please. NAMI is the National Association for Mental Illness, and actually here's some advice that they gave on their website. And one is to educate yourself. You find, as you know, the more you educate yourself about either any disability or about what the person is going through, that will help you in terms of, your attitudes and judgments, and that will be probably reflected in your language. See the person, not the condition. And I know sometimes it feels wordy to say the person with schizophrenia, the person with bipolar disorder, but it still, again, helps you see the person. I saw a webinar where a doctor was talking about this too, and she was saying how she often used to refer to people in rooms by their condition, and she'd say, oh, let's go see the appendix in room 702. And then she, I guess, was looking at her language, and then now they're all looking at it very differently. And again, take action when you need to.